Welcome to The Explainer. Today we're diving into a really important paper from the Dental Clinics of North America Journal. It's called Occlusal Splints, What is the Evidence? And you know, this one really makes you stop and think about one of the most common things we do in our practices and what it all means for our patients.
You know the occlusal splint. For over 100 years, it's been our go-to, right? A patient comes in with jaw pain, muscle soreness, any kind of TMD, and it's one of the first things we think of. It's a cornerstone of our practice for sure.
But, and this is the big question the paper asks, what if the reasons we think they work are, well, not quite right? What if our understanding is based on old ideas? Let's look at what the actual clinical evidence says about how effective they really are, and even how they work in the first place.
Okay, so let's get right into it. The authors just hit the nail on the head with this quote. I mean, think about it. For something we do all the time, there's still a ton of disagreement and confusion about which type to use, when to use it, and if it's even going to work. That's kind of wild, right?
So to really get what's going on now, we got to take a quick look back. The way we think about splints has changed a lot, and that history really matters.
I mean, check this out. The idea of a splint didn't even start in dentistry. It was an orthopedic tool for broken bones way back in ancient Egypt. It wasn't until the 1930s that we started using it for TMDs. And today, well, that old-school mechanical thinking is being totally re-examined through this new lens, a more modern, evidence-based, bio-psychosocial approach.
And this is where we hit the big paradox that the article really unpacks. We've been using these things for decades with a lot of confidence, but when you look at the actual science, the evidence is surprisingly shaky and full of contradictions. Okay, just look at this table. It tells the whole story. The research is completely split. On one side, you've got studies saying, yes, they give temporary pain relief. But then on the other side, you have just as many high-quality studies saying, well, actually, they're no better than just talking to the patient, or sending them to PT, or giving them some exercises. This is the core of the whole problem. So this just makes you wonder, right? If it's not the simple mechanical fix we all thought it was, then what is going on? I mean, we've all seen patients get better, so how are splints actually working?
Well, the paper digs into four main ideas that try to explain what's really happening. And these aren't just about simple mechanics, they're about how we might need to change our whole approach to treatment planning.
All right, hypothesis number one. This is the one we all learned in school, right? The splint is basically a shock absorber. It takes the hit from all that clenching and grinding, spreads out the force, and gives the TMJ a break from all that stress and inflammation. It's the classic mechanical story.
Now, what about this one? Regression to the mean. It's a statistical thing, but it's really simple. Think about it. Patients come to see us when their pain is at a 10 out of 10, right? At its absolute peak. But pain, especially chronic pain, goes up and down. So there's a good chance it was going to get better on its own anyway. The splint might just be along for the ride.
Okay, hypothesis 3 is fascinating. It's all about the brain. The idea is that the splint is this foreign object in the mouth, and it completely changes the signals going to the brain. It's like it makes the brain suddenly aware of what the jaw is doing, and that awareness can be enough to break the habit, to interrupt those clenching patterns.
And finally, number 4, the placebo effect, or what we call non-specific effects. And this is huge. Maybe the magic isn't in the piece of acrylic itself. Maybe it's in the act of doing something, the patient's belief it will work, the relationship they have with you, the clinician, or maybe it's just that we give splints along with other good advice, like physical therapy.
Now, this all leads to a really critical diagnostic point. We have to figure out, is the pain coming from the jaw itself, that's peripheral sensitization, or has the central nervous system gotten involved and started amplifying everything? That's central sensitization. And this is key because if it's a central issue, a splint by itself is probably not going to do much. Okay, so that's the science. But what do we do with all this? How does this change what we do in the clinic every day? Well, the paper boils it all down into some really clear practical takeaways for us.
The big takeaway here is that we have to shift our thinking. It's not one size fits all. A good diagnosis is everything. We have to see TMDs more like an orthopedic problem, not just a tooth problem. And that means we have to accept that there's just no strong evidence linking occlusion to TMD. So absolutely avoid irreversible stuff like equalization. It's all about bringing in other experts and looking at the whole person.
So let's wrap this up. When you put it all together, the evidence is really pushing us towards 3 big shifts in how we think about splint therapy.
Okay, number 1, We've got to shift from just looking at the mechanics of the bite to looking at the whole patient, their biology, their psychology, everything. Number 2, we have to stop thinking of the splint as a cure. It's not. It's a tool. Just one tool in our toolbox. And that leads to number 3. We need to use it as part of a bigger plan. The evidence is clear that splints work best when they're combined with other things like physical therapy and counseling.
So at the end of the day, this entire review leaves us with one powerful question to ask ourselves. Are we treating the patient, or are we just treating their teeth? And thinking about that really changes everything. It forces us to move past old habits and embrace an approach that's way more complete, way more evidence-based, and ultimately, way better for our patients.